Hello, everyone. My name is Clifton Moe, and I'm one of the multiple myeloma physicians and clinical investigators here at Dana-Farber. Also the director of the autologous stem cell transplant program for myeloma here and the associate director for clinical research. And it is my honor and pleasure to bring you all the most recent updates on systemic therapy for patients with newly diagnosed multiple myeloma. I've titled my talk From Doublets and Transplant to Quads and Beyond, just to give us all a better understanding of where we've been really over the past 20 years and where we're headed. These are my relevant disclosures. So I want to start off just with a little bit of a walk through the past couple of decades in terms of drug development and advances in standard of care. This is a slide depicting recent FDA approvals and is already antiquated given even more recent approvals of newer therapies such as CAR T-cell therapy, bispecific antibody therapy, really exciting new advances that will be described in other lectures within this symposium. But right now I'd rather focus on a couple of decades ago and the first drugs that were actually ever FDA approved for myeloma. This started in 2003 with the approval of bortezomib, or Velcade, due to the preclinical and clinical leadership of Drs. Anderson and Dr. Richardson here before my time, developing this drug and showing it to be very effective in multiple myeloma. This was followed shortly thereafter by the FDA approval of lenalidomide, or Revlimid, and really ushered in what is now known as the novel agent era for multiple myeloma. So another timeline here in terms of studies. In 2002, the very first phase 1 study of Revlimid in multiple myeloma was published by Dr. Richardson and team here. And then a few years later, even more really encouraging data, not only in terms of efficacy of Revlimid combined with dexamethasone, but also tolerability with a favorable toxicity profile compared to the older IMiD-type drug, thalidomide. In 2008, Velcade actually gained approval for use in all myeloma patients to include the first line, which was a very big advancement. And then last but not least, the component of the myeloma regimen that is least talked about, or the steroid component. This was a landmark study led by Dr. Raj Kumar from the Mayo Clinic, showing that lower dose dexamethasone, what we now know as standard dose, which is 40 milligrams or equivalent once weekly, was actually better and resulted in better outcomes for patients than what was previously considered standard dex dosing, which was 40 milligrams for 4 consecutive days, rather frequently. So this is the first decade of the novel agent era. And as you can see here, we're talking about single drugs, or we're talking about dexamethasone paired doublets in therapy, which was really considered standard of care back then. Still at that time, there was no argument that transplant was the standard of care and a life-saving form of chemotherapy based on the clear survival advantage seen, in the 1990s with autologous transplant. So this here is just a little background on why regimens like RVD were then developed and really became the consensus standard of care in the following decade. So this is out of a Dana-Farber lab over 20 years ago, a study led by Dr. Mitsiadis here, that really showed the potent synergy between these two kinds of drugs. So here we have the percentage of myeloma cell death, or how effective these drugs were in the test tube, so to speak, or in preclinical models. The IMiD by itself, resulting in about 30% cell kill. And then this was Velcade before it had a name, percent cell kill by itself. But then when you look at the combined effect of both of those together, it was clearly more than the additive effect of each individually alone. So this really proved a potent degree of synergy between these two drugs, which led to the clinical development of RVD. So the very first RVD study came out in 2010, and Dr. Richardson reported a 100% response rate, really, depths of response that we clearly were not seeing with the doublet regimens. And that really ushered in the combined novel agent era, or the era of IMiD, PI, DEX combinations, such as RVD and KRD, as really being, if not the official standard of care, really the de facto standard of care over the subsequent decade. So several years later, we had the SWOG 777 study, which really confirmed the superiority, the clinical superiority of RVD over Revlimid Dex alone. This was a trial for patients for whom immediate stem cell transplant was not planned. They were patients who were younger than 65, older than 65. So it wasn't necessarily a transplant eligible or ineligible patient population, but kind of a combined one. So in any case, we clearly see progression-free survival, but also an overall survival advantage to the combined triplet of RVD versus Revlimid Dex alone. So not to forget about carfilzomib, or Kyprolis, which came on the scene, a little bit later than Velcade, but also is a unquestionably efficacious and generally, well-tolerated proteasome inhibitor. So for years, we really didn't have any prospective head-to-head data of the RVD triplet versus the KRD triplet. That changed a couple of years ago when the results of the Endurance study came out. And not to belabor the point, but here we see the progression-free survival curves, which are essentially superimposed on top of each other. So neither regimen demonstrated superiority over each other in terms of efficacy. Now, there were some limitations to this trial. There were a considerable percentage of high-risk patients who were actually excluded from this trial. So there is at least a possibility or a hypothesis that for some high-risk patients, carfilzomib may have an advantage, although I don't think that's been definitively proven. What we did see in Endurance, though, was clearly a difference in the side effect profile, which you almost didn't need to do the study to know. I mean, anybody who's received both of these drugs kind of knows, what the differing side effects are. So clearly, we see more neuropathy with the Velcade-containing regimen. But as you can see here, the rates of high-grade neuropathy were not zero, but rather low. And you didn't see that with the carfilzomib-containing triplet. However, you did see an increased incidence of pulmonary, cardiac, and renal events, which were not common per se, but obviously, kind of vital organ toxicities that did occur uncommonly. So I think, the story continues. The conclusion of the investigators of Endurance was that KRD did not prove superiority over VRD. I think there are those who really kind of, prefer KRD, who said that, the results of the study were the converse of that, and, RVD didn't prove superiority. So in any case, I think they're both very good and acceptable triplet regimens that are still being used very commonly in the United States today. So back to the timeline of FDA approvals, and we see here arriving on the scene about 8 years ago was daratumumab, which was first approved essentially as a single agent and had the ability to reestablish response really by itself or with the help of dexamethasone. But subsequent studies in the relapse refractory setting showed that really, DARA containing triplets were preferable to non-DARA containing doublets, no matter what study you looked at. So Pollux looked at, DARA Revlimid versus without, DARA Velcade, DARA carfilzomib, DARA pomalidomide, and no matter what study you looked at, the addition of the DARA significantly improved the efficacy of the novel agent-based doublet regimen. So, in my opinion, the DARA is kind of like, the red hot of myeloma, or whatever your favorite condiment is, and then, whatever you add it to, it just kind of makes it better. So not surprisingly, the follow-up to studying DARA in relapse disease was to see how much benefit it added to patients in the first line. So I'm really going to focus on the Griffin study, which was a study that we co-led here, and was updated results were reported a little over a year ago by Dr. Laubach at ASH. So this was the DARA RVD study. Now, this was not a phase 3, but rather a phase 2 study. But it did involve a randomization to RVD with or without daratumumab for patients who were considered transplant eligible with newly diagnosed disease. So you see here the general schema. Patients got 4 cycles of either the quad or the triplet, and then everyone went to high-dose melphalan with autologous transplant, followed by 2 additional consolidation cycles of either the quad or the triplet, and then to either 2-agent dara-Revlimid maintenance versus Revlimid by itself. So basically, patients who were randomized to receive DARA right out of the gate kind of stayed on DARA, and those who were randomized to RVD alone did not get DARA on this study. In the maintenance phase, I would note that the DARA was designed to continue for the first 2 years of maintenance. The final analysis recently occurred and was reported, and this was after all patients had completed at least 1 year of long-term follow-up after completing the on-study maintenance therapy. So what we see here, it's a little bit of a busy slide, but this just really showed that responses deepened over time in both arms of the study. However, when you look at the depth of response, it was clearly superior with the addition of daratumumab, with well over 80% of patients, both at the end of 1 year of maintenance as well as at the end of the study, achieving a complete response or better, as opposed to just 60% of patients who did not get DARA. So really at all time points, both early and late, the DARA improved kind of both the rapidity as well as the depth of response. And then when you look at MRD, so again, I think most of us are probably familiar with the concept of MRD, minimal residual disease negativity, which is basically just a newer way of looking for deeper and deeper responses. This study used what's called next generation sequencing, or a validated MRD study called clonoSEQ, to look for elements of myeloma cell specific DNA in the bone marrow. This would roughly equate to, if you have MRD positive findings, to finding 1 residual myeloma cell out of about 100,000 normal cells in the marrow. And so achieving MRD negativity was a key secondary endpoint of this study. And clearly we see that more patients who got the DARA-containing quad achieved MRD negativity compared to those who got RVD alone. When you look at what's called the intent to treat, or kind of, all-comers population of the study, 62% versus 27%. And then when you look at actual MRD evaluable patients, so everyone who you can actually, have the sample to look for at the time point, 81% versus 44%, clearly achieving statistical significance. So not quite, but almost a doubling, really, of MRD negativity just by adding the monoclonal antibody. And if you go even deeper, so again, kind of looking for the 1 in a million residual, or the 1 residual myeloma cell out of 1 million cells, then you see here the benefit of DARA still holds up. So like the kind of classic ways of measuring response in the blood, the MRD negative rates deepened over time. Again, in both arms of the study, not just the DARA-containing arm, but patients who are only on RVD, you see that more and more of them are becoming MRD negative, throughout their treatment. So, I think that is an important point, because, there's a lot of, questions that I get a lot, from patients and oncologists alike about, what's the prognostic significance of not achieving MRD negativity, and if I'm still MRD negative after 4 cycles of quad therapy, is that bad for me? And I think the answer is it's not quite clear, and it's not totally straightforward. How much we should hang our heads about not achieving MRD negativity at relatively early time points during treatment. So clearly an improvement in RVD, but obviously the magnitude of benefits, the percentage of patients who do continue to deepen their response to MRD negative responses is clearly superior with the DARA-containing quad. And then last but not least, we're talking more and more not only about MRD negativity as like a single time point, but what we call durable or sustained MRD negativity. With that perhaps having even more prognostic value than just kind of a yes or no MRD negative at one time point type of approach. So this study did look at patients who achieved MRD negativity for at least 6 months or for at least a year in the 4 versus 3 drug arms of the study. And you see here that the amplification of the benefit is even more than just when you look at just the general MRD yes or no at any time point question. So 15% versus 48% of patients on the study achieved MRD negativity with the triplet versus the quad. And then when you look at 1 year, again, 13 versus 44%. So really like a tripling of sustained MRD negativity with the addition of daratumumab. So ultimately, we're looking for treatments that not only have really impressive early responses, but we're looking to keep patients in remission for a very long time. And at the end of the day, we're looking to continue to improve prognosis, longevity, and overall survival. And we don't yet have those data, but we do already see a separation in the progression-free survival curve. So again, this is not survival. This is, really kind of another way of saying, how long does the first remission last? And now we do see a clear separation of curves in favor of the DARA-RVD with about a 55% reduction in the risk of disease progression or death, which is how progression-free survival is defined, with the addition of DARA to RVD. And you see here that the separation of curves does begin beyond 1 year of maintenance. So with these kinds of studies, it does take time, but we're already seeing a clear improvement in PFS with DARA-RVD. The good news for everybody is the overall survival numbers still look really good, regardless of whether the patient got the quad or the triplet. So I think, the data are nowhere near mature enough to demonstrate or prove a longer term survival advantage to giving DARA up front. But certainly, we'll continue to follow the progress of the data on this study. So we've talked a lot about the efficacy of the DARA-containing quad treatment, but of course, there really is no such thing as a free lunch in general. And whenever you introduce more drugs, I mean, by definition, you're introducing more risk and potentially more side effects. What we, I've for the sake of time, I'm not going to include every single kind of side effect slide, but overall, the rates of both, hematologic, low blood cell count toxicities, as well as non-hematologic toxicities, were pretty darn comparable between the quad and the triplet arms of the study. What we did see, though, was clearly a small but noticeable increase in rate of infection in the quad arm. So most of them were, low grade or non-serious upper respiratory infections. And this is kind of, I think, a helpful slide because it does show that, visually here we see, any sort of grade infection. We saw a slight increase incidence of that with the DARA-containing quad than with the RVD by itself. But a couple of things. One is you do see that the rate of infection does peak right around here at the end of consolidation, or in other words, a couple of couple cycles after the patient underwent, immunosuppressive autologous stem cell transplant. And then you see kind of a plateauing and then a leveling off of infections at 2 years and beyond in the maintenance phase. So I think that's also important because it's not like the rate of infection remains high and persistently high in the years afterwards, but it's kind of a time-dependent risk of infection. And then also importantly here at the bottom, we see the rates of grade 3/4 infections, or kind of more worrisome infections. And clearly in both the triplet and the quad arm, we see low rates in both arms, and really, no significant trend towards higher rates of higher grade infections with the quad versus the triplet. Okay, so that's Griffin. I think that's probably enough talk and enough slides about Griffin. Just very briefly, the other relevant studies looking at the value of DARA in the first line. Cassiopeia was a European study. Again, it was very similar to Griffin. It was larger though, so it was a phase 3 study. And also, unlike Griffin, it did include a second randomization when patients were done with the initial phase of therapy to either daratumumab maintenance every 8 weeks or nothing, or no maintenance. And so this study, just like Griffin, showed significant improvement in depth of response, significant improvement in progression-free survival. And the other reason I wanted to bring it up, even though we really don't use thalidomide in the United States anymore, much at all, in the first line setting at least, is this so far what we're seeing in the maintenance phase is that patients who did not get the DARA as part of the quad therapy, but then did get DARA in maintenance, there seems to be a benefit versus nothing in terms of progression-free interval in those patients. But in those who got the DARA-containing quad, who then continued DARA maintenance by itself, there at least so far hasn't been a significant added benefit to the maintenance DARA. Now, does that mean that DARA is a bad drug or an ineffective drug in the maintenance setting? I definitely don't think we can say that. Number one, the DARA was given by itself as opposed to partnering, with the Revlimid as it did in Griffin, and we know that these drugs help each other work. And it was given every 2 months instead of every month, which is, or every 4 weeks, which is, generally how we give maintenance DARA here. But in any case, I think the jury is still out, so to speak, in terms of, what the best maintenance regimens and best maintenance drugs are. And then just one slide here on the MAIA study, although this is a pretty important study. So this is the randomized phase 3 study of daratumumab, Revlimid, and dexamethasone, or DRD, versus Revdex alone without the DARA in a transplant ineligible population. So patients who either by way of age or comorbidities or both were considered not appropriate for high-dose chemo stem cell transplant by their physician. And so this study, just to cut to the chase, gave people DRD versus RD, with the intent to continue, the full regimen until eventual progression of disease. And we saw a clear improvement in efficacy in terms of response rate, depth of response, progression-free survival, and MRD negativity. And importantly, we actually now see a survival benefit. So not just a progression-free, but an overall survival advantage seen to DRD versus RD, with about a 32% reduction in risk of death with use of this triplet. As of the most recent update of this study, which was from ASH just a couple of months ago, we see that the median progression-free survival interval with DRD is now just over 5 years, as opposed to 34 months with the RD alone. And so those are, objectively pretty impressive numbers. So I think that this is a regimen that is definitely worth considering for patients who want to get a very efficacious regimen in the first line. but may not be appropriate for a 4-drug regimen in terms of the risks and side effects that come along with that. So I do also want to mention that in the RVD world, that SWOG 777 study still gave patients "quote unquote" RVD classic, and so that involved giving Velcade twice a week. There was an important study out of Boston here, Dana-Farber MGH-led study, looking at what we now call RVD Light, which really preserves all 3 components of the RVD, dials down the dosing of all 3 components, gives Velcade only once a week, Revlimid 15 milligrams, lower dose dexamethasone. And what we saw from the RVD Light study was still a very clinically meaningful degree of effectiveness of the regimen, with a median progression-free survival of about 3 years, with dose attenuated therapy, with a lot less peripheral neuropathy. So I think only 2%, maybe 2 to 3% of patients had grade 3 neuropathy, with the other patients having grade 1 to 2. And the oldest patient on that study was in their early 90s. So again, we don't have any head-to-head data on RVD Light versus DRD. The doses of the drugs in the RVD Light study, were a bit lower. In the Maya study, the intent was to start patients on 25 milligrams as opposed to 15 milligrams of Revlimid. So I think there's a lot of unanswered questions. How much of the impressive data from DRD is due to the DARA, versus kind of the other differences in the studies? So on the one hand, I think both regimens are still very reasonable options for transplant-ineligible patients in the first line. I mean, what we do know, again, is clearly a different side effect toxicity profile, with most patients getting, at least minimal, usually minimal neuropathy with RVD Light, and then perhaps with, a more of a, infection risk signal with the DARA-containing triplet. I think you'll get different answers from different myeloma doctors as to what the best regimen is in the transplant-ineligible population. In my opinion, both RVD Light and DRD are still very good options, and it takes a good, conversation with the patient and to inform them as much as possible as to what we do and don't know and what the side effect profiles are before deciding on the best regimen. Okay, so enough about that. Now, there are many other recent and ongoing studies that are noteworthy and of interest in this space. I'm just going to highlight several of them, though. The Manhattan study, which was recently published by the Memorial Sloan Kettering Group. This was a study of DARA-KRD, so with carfilzomib instead of bortezomib, without the intent to transplant up front. So patients got up to 8 cycles of DARA-KRD, and then went to maintenance. And the results of the study were very encouraging, with the last time I checked a 71% MRD negativity rate with DARA-KRD by itself without transplant. There is the MASTER study, which is also a DARA-KRD study with transplant. But one of the novel things, or the novel aspect about this trial, is it actually evaluates early stoppage of therapy in patients who achieve and sustain MRD negativity. So, this study is ongoing. Overall, the results are looking really good with, deep responses, MRD negativity in excess of 80%. And so we look forward to seeing, continued updated analysis from the MASTER trial. There is out of Germany a trial that was just recently reported looking at the newer or more recently FDA-approved anti-CD38 monoclonal antibody isatuximab, or Sarclisa, as a substitute for daratumumab when given in the quad setting with RVD. So this was a kind of a Griffin-like study that gave ISA-RVD for what is the equivalent of 6 cycles of classic therapy followed by transplant. But what was noteworthy about this study was MRD negativity was looked at before transplant, and using a little bit of a different technique called next generation flow, but still, an accepted, way of measuring MRD. There was a 50% MRD negative rate, even before transplant with this isatuximab containing quad. So more to follow from the study, but we now have two CD38 antibodies that have been FDA approved in the relapse setting that are being actively studied in the newly diagnosed setting, both here at Dana-Farber and elsewhere. And last but not least, we have an ongoing study looking at quad therapy in transplant ineligible patients. So this is what we here at the Farber call the RID-DARA study. So DARA, basically a DARA RVD-like regimen, but subbing out Velcade for the less neurotoxic ixazomib or Ninlaro, which is the orally available proteasome inhibitor given once weekly. We are, again, actively enrolling patients and studying both the efficacy as well as the tolerability of what we hope will be, a well-tolerated quad in patients who are still a bit either old or with maybe too many comorbidities to safely consider transplant. Okay, so key points in terms of the evolution of novel agents and immunotherapeutic agents in the first-line setting for patients with myeloma. I think it's pretty clear that quads are more efficacious than triplets in terms of rapidity of response, depth of response achieved. But are they standard of care now? I think you'll get different answers, as you probably know now, listening to different myeloma experts. You often get multiple different opinions from different people, and I think you probably still will in this case. In my opinion, for patients who are transplant eligible, I don't know that quads are a bad idea for anyone. I mean, I think there is definitely an argument for giving someone the best drugs that we have, as long as they're safe and well tolerated. In the first line, we know that there is a correlation between depth of remission and length of remission. And so again, there is no free lunch, and with more drugs, you may be at risk of more side effects or complications. But based on what we're seeing right now, the monoclonal antibody doesn't add a prohibitive level of added risk or toxicity to the RVD or KRD-like regimen. Patients who have high risk disease, I think there's an especially strong argument for offering these patients quads. So an ongoing debate about the value of quads, but I think a greater and greater percentage of newly diagnosed patients will be getting treated with monoclonal antibody IMiD proteasome inhibitor as opposed to just two of those. Okay, so if quads are not yet standard of care, what is needed? Do we need to see an overall survival benefit? I think some people may say yes. I personally think that there's an argument for going with the impressive data that we have now in terms of offering patients our most effective therapies, rather than waiting who knows how many more years we would need to wait to actually definitively prove an advantage in terms of this gold standard endpoint. Both RVD light and DRD, I think, remain very acceptable choices for patients who are considered transplant ineligible, although certainly with the impressive data coming from the MAIA study, I think we may see more patients who are offered DARA in the first line by their oncologist, even if they are not considered transplant eligible. I think it's clear that more patients will be exposed to drugs like daratumumab and isatuximab earlier and earlier in their lines of therapy. And so we as myeloma oncologists will need to anticipate the need for effective regimens after those types of drugs stop working. And then most importantly, we definitely are continuing to make progress in treatment of patients with newly diagnosed myeloma. And I'm confident in making the prediction that progress is going to continue over the next several years and beyond. So briefly, I also wanted to provide an update on transplant. Again, this is probably worthy of a separate 1 hour talk, but I'll be as concise as possible. So, kind of a brief reminder as to where transplant came from. Really started in the 80s and the mid 90s. Was became accepted as standard of care due to the clear overall survival longevity advantage of transplant versus lower dose, lower intensity chemotherapy. Of course, that was in the 90s before all of these drugs I just talked about were FDA approved. So for years, we really didn't know what the added value of transplant was in the setting of regimens like RVD and KRD. But in the absence of data to suggest otherwise, it continued to be standard of care, and rightfully so. In 2016, we had the first reported results from the European IFM 2009 study, which again randomized patients to either an early or a delayed transplant approach in the setting of RVD induction and consolidation. Back then, we saw a 14-month progression-free survival advantage, no difference in overall survival. And then again, at the updated analysis, which was now a couple years old already with a median follow-up of about 8 years, we continue to see the progression-free survival advantage. It was about a year instead of 14 months, and still completely superimposed overall survival curves at about 8 years. So no indication that transplant was helping patients live longer on this study, as opposed to the studies that we saw in the 90s, which showed otherwise. So really a testament to the added efficacy, improved strength of therapy with RVD compared to what came before it. Also, I should note that on this study, patients received 1 year of Revlimid maintenance and then stopped. So that's important because we now, as of last June, have the first reported results from the determination study, which was the quote unquote sister study to the IFM trial that I just mentioned, and was designed identically in terms of RVD with or without early transplant. The main important difference is that patients on the determination study stayed on Revlimid maintenance until the myeloma began to progress or until they developed, intolerable side effects from the maintenance therapy. So this study was reported as a excuse me, as a plenary at the ASCO meeting in Chicago last June by Dr. Richardson. Again, we see that the schema is identical with the randomization to collect and store versus collect and transplant after initial RVD, and then the long-term maintenance. So here we see a breakdown of patient characteristics showing, really comparable characteristics between the transplant versus no transplant arm of the study. Both arms contained almost 20% patients of Black African American descent, which was a very notable improvement in terms of inclusiveness in cooperative group clinical trials here in the US. Also, in terms of disease characteristics, we see pretty comparable percentages of patients with stage 1 versus 2, 3 disease, and those with high-risk cytogenetics. So just to cut to the chase here, the primary endpoint of progression-free survival was found to be still in favor of the early transplant arm. And interestingly, the addition of long-term maintenance, as opposed to just 1 year of Revlimid maintenance, if anything, seemed to magnify the progression-free survival benefits, or the length of remission benefits of transplant. So we saw a median progression-free survival of about 21 months longer with transplant than without on this study, with a median follow-up of just shy of 6.5 years. So when you look at the cytogenetic risk subgroups, again, the caution here is that the study was not powered to detect, differences based on these subgroups. But we see here that in the high risk subgroup, we may, see an advantage emerge to transplant in terms of, the kind of the visual separation in these curves. However, statistically, it did not reach significance. And in the standard risk, we see, a benefit to transplant still in terms of progression-free survival. But again, this is an ongoing analysis. When you look at the MRD analysis, again, this is very preliminary and I think is kind of hypothesis generating as opposed to proving anything right now. But here you see patients who achieved MRD negativity, either with or without transplant, and you see that they're pretty comparable and not really, statistically distinguishable from each other, as opposed to patients who did not achieve MRD negativity, whose remissions on average lasted for shorter periods of time. Interestingly, those who did not achieve MRD negativity with transplant may still have done a little bit better than patients who did not achieve MRD negativity without transplant. So I think, again, the jury is still out in terms of how to interpret the MRD data, but clearly this part of it at least is very encouraging in that, patients can do well who achieve these deep responses, potentially even without transplant. Importantly, just like the IFM study that I just discussed, the overall survival analysis still shows completely superimposed curves between the two arms of the study. Again, we still only have, a median 6.5 years of follow-up. So it is conceivable that these curves could separate over the coming years, although we don't see any indication that they are. So again, we now have 2 RVD with or without early transplant studies, both of which show a progression-free survival advantage at 6+ to 8+ years of follow-up, neither of which show at this time any separation of overall survival curves in favor of transplant. In terms of the individual cytogenetic risk abnormalities, again, it's hypothesis generating at best, but you see a trend towards improved progression-free survival across the different high-risk features. But again, when you look at overall survival as a secondary endpoint, these plots are kind of falling more in the midline. So a little bit of a question as to, how much patients with high-risk disease specifically are benefiting from early transplant. So more to follow on this. And then importantly, toxicity and adverse events with transplant versus then without. You see an overall, so the absolute, incidence of fatal adverse events on the study was low in both arms. 1.6% is obviously not 6%, but, is still 1.6% fatal outcomes or fatal adverse events with RVD plus transplant versus 0.3% with RVD without transplant. So you can take that for what it's worth. And then obviously the short-term toxicities of the in-hospital toxicities of transplant, mucositis, nausea, fatigue, fever, pneumonia, obviously considerably higher with transplant than without. And then in terms of kind of late toxicities, again, I think, there's more to follow on this discussion. But, we know that there's potential for our treatments to increase risk of other cancers. And the one, arguably the one type of secondary malignancy that we are paying most attention to is what's called secondary leukemia. And so far what we're seeing, again, overall, the incidence of what we call secondary MDS, AML, or acute myeloid leukemia, overall incidence is low on this study. But when you look at kind of numerically the transplant versus non-transplant arm, we see 10 patients on the transplant arm that have gotten MDS or AML versus 0 so far on the non-transplant arm. So I think, over the coming, few to several years, we'll kind of see how these numbers play out. But so far, it does seem, pretty clear that, there's a small absolute but increased relative risk of, these kind of myeloid leukemia complications, which can be very difficult to treat in patients who get early transplant. Okay. So key points about transplant is that at least in the setting of triplet therapy, RVD, from two, very, well-designed, well-run phase 3 studies, we clearly see a progression-free survival advantage to early transplant versus the collect and store approach. And we also see a pretty clear advantage in terms of long-term Revlimid maintenance versus short-term Revlimid maintenance between the determination and the IFM studies. We are not seeing an overall survival advantage with 6+ to 8+ years of average follow-up on these studies. Some would say that we have not yet seen an overall survival advantage, and we may still see a survival advantage. And so to strongly consider, kind of early transplant for all for now, I personally, don't know that that's that I completely buy that argument. And I think that even though we have, imperfect data, we have the data that we have. It really does take a good sit-down session or two with the patient to inform them as much as possible about, what we know, what we don't know, and kind of, what risks they are and aren't comfortable taking with their own treatment. So again, definitely, as Dr. Richardson says, it's no longer one size fits all. And I think it should be much more of an individualized approach. In any case, the proverbial room is still split in terms of interpretation of the determination in the IFM data. So clearly, some myeloma and transplant doctors who, are still, offering early or, strongly recommending early transplant to most of their patients. And then there's people like me who are kind of a little bit more maybe in the middle. So clearly many patients will continue to receive early transplant and many may not. I should note that we have essentially zero randomized quality data like we have in the determination in IFM studies. We just don't have the same data in the setting of quad therapy, just because these, DARA-containing quad regimens are so relatively new. So when somebody asks me what the added value of transplant is after, DARA-RVD or DARA-KRD, the most honest answer that I can give is I don't know, but clearly we see that these 4-drug regimens, as I described, are working so much better than the 3-drug regimens that came before them. So for whatever that is worth. For patients who don't elect to go for an early transplant, who still are young and medically appropriate for transplant in the second line or beyond, I do think that a stem cell collection in first remission should still be offered, so as to not take that option off the table for a delayed transplant should the patient need or want one down the road. I do think that MRD-driven trials, as opposed to just kind of looking at MRD in retrospect, but actually trials that are going to be using MRD status to guide therapy, both in terms of escalating intensity and potentially de-escalating or maybe even stopping therapy based on MRD status, are needed. And these trials are actively being planned, if not ongoing. And likewise, I think we need trials that compare these very promising and exciting new immunotherapies, such as bispecific antibody therapy, CAR T-cell therapy, to these older, power horses, powerhouse consolidative therapy like transplant. And so kind of compared the very old and the very new to see, how we should really be optimally treating patients in the first line of therapy. These trials are also needed and are also either being planned or actively underway. So, and with that, I'll end this talk, and I thank you for your kind attention, and look forward to any questions that may be out there. Thanks so much.